Welcome to the ANPT's Synapse Through Time webinar in celebration of the APTA's Founders Day event, which starts tomorrow, January 15th, 2021. I'm your moderator tonight, Dr. Denise Gobert, Chair of the ANPT Historian Archives Committee. And as we celebrate 100 years as a profession, we would like to acknowledge that the neurologic physical therapy practice can also celebrate significant milestones over the past years, such as the formation of our academy in the APTA in 1977. And that was a start with just 75 members. Also, we had the approval as a specialty practice in 1982, and then the formation of special interest groups in 1992. So overall, through the years, we've been growing, we've been getting better. And from those 75 members that first started our academy, now we are 6,200 members strong. So truly, we have come a long way. Now, to help us with our reflections of our past, our present, and our future, we are happy to introduce our panelists tonight. So first of all, I am excited to introduce Dr. Pamela Duncan, who is a nationally and internationally known expert with many years' contributions to our profession, with a focus on public health, outcomes research, and healthcare delivery in an ever-changing and challenging medical model. Thank you, Dr. Duncan, for coming tonight.
Thank you, Denise.
Second, I am also excited to introduce Dr. Fay Horak, who is a nationally and internationally known researcher with many years of service to our profession, with a focus on innovative work to optimize diagnostics and treatment of our special patient populations using new technologies to measure balance and mobility. Thank you, Dr. Horak, for also coming tonight.
Thank you for inviting me.
In addition, it is my privilege to introduce Dr. Donald Neumann, who also has been a nationally and internationally known major contributor to physical therapy education over several years with several textbooks and book chapters that are in use throughout the world. So thank you, Dr. Neumann, for coming tonight.
My pleasure.
And last of all, it is my honor to introduce Dr. Anne Van Sant, who has been a game changer in our profession for many years with teaching and research in the lifespan development of motor behavior and movement patterns with a focus on pediatrics. In addition, I must add that she has served in several leadership roles in the association, including past president of the Neurology Academy and past vice president of the Pediatrics Academy and editor-in-chief emeritus of Pediatric Physical Therapy Journal. So thank you also very much, Dr. Van Sant, for joining us tonight.
It's a pleasure to be with you all.
So to be time efficient, we have a wealth of expertise on our panel. And so what we have done is we have structured our agenda to include a couple of things to keep us engaged and to discuss various topics. We're going to address three topics in general: the past, the present, and the future. Our panelists will each be allowed to answer the questions with some prepared responses. But afterwards, we will encourage a few comments and questions from the audience. So be prepared to also speak on the various topics with our panelists. So if you're ready to go, I think I'm ready to go. So let's think about that movie Back to the Future with that DeLorean. Well, we have our vehicle ready to go back to the future with our first question. And that question is, a popular saying is that we can stand on the shoulders of great leaders of the past to help move forward into our future. In your opinion, which leader or innovation from our past contributed an important milestone in our profession and at the same time laid the foundation for your successes in your personal career? And I'm going to hand off the first question to Dr. Ann Van Sant.
Thank you. This question took a lot of thought because I've been fortunate to work with amazing leaders in our profession from the day I walked into physical therapy school, as they used to call it, and was my program director, was a past president of APTA. And then when I did my master's, my program director was a past president of APTA. So I've been surrounded by amazing people. But I think the person who influenced me most was Helen Hislop. It's in a formal relationship. In fact, I came to know Helen through my college roommate, who was a master's student in her program at Southern Cal. And it was the first time I really met her and got to know her was in 1975, at the time that she gave the Not So Impossible Dream lecture as the Mary McMillan lecturer. Well, she was pretty impressive, but some of the things that we talked about, and in fact, many of them were outlined in her Not So Impossible Dream lecture, had to do with specialization within the profession and her ideas about that, and how it was a really good force for growth in the profession. Also, the need for scholars, people who were willing to go the extra mile and get their PhD. And those things, those discussions way back in 75 were really the foundation for what I became in PT.
Love it. I love it. That was a nice walk back in history when we were forming our kind of specialty in neurologic physical therapy. Thank you for that. Well, I'm going to shoot the same question to Dr. Neumann. What are your memories of the past?
Well, I don't quite go back as far as some of my people that I talk about, but physical therapy, the profession really has been strongly influenced by, I think, many pioneers who practiced during the polio epidemic in the middle of the 20th century. Talking about people like Sigmund Brunkstrom, Florence Kendall, Catherine Worthingham, and many others who really strove to try to understand the actions of individual muscles. And this desire to learn how individual muscles worked, which really was the hallmark of polio because there were specific paralysis in individual muscles, it really was related to three things. It was very clinically relevant because at the time you need to understand how muscles balanced a joint so you could understand joint deformities and be more preventive. You needed to understand about creative bracing, and you certainly needed to be able to know specific muscle actions so you could do our manual muscle testing, which was a way to follow the patients who actually had the paralysis due to polio. And interesting, the manual muscle testing that we all know and love as PTs, really that was used to document the efficacy of the Salk vaccine that was first given in 1955 that ultimately eradicated or virtually eradicated polio in the United States. So put this in perspective, put the pioneers in perspective. They function in the pre-EMG era, right? So their understanding how a muscle functioned was based on palpation, observation, clinical reasoning, and a lot of curiosity. So I think it's ironic that although the polio epidemic served as a laboratory really to understand the role of a single muscle, the more lasting lessons really were how muscles work together in synergy. And I'd like to recommend a paper written by Sigmund Brunkstrom in 1941, a physical therapist, published in the journal Bone and Joint Surgery. And that's a journal written by surgeons and for surgeons. And this was entitled Muscle Testing Around the Shoulder. And one of the backgrounds for that paper was to understand the logic of tendon transfers that you would do after surgery. So I think these pioneers really left a lasting mark on the profession, on me, and some students I've been involved with. So I think their passion really was for the sake of really learning, but for the sake of improving the well-being of their patients. And I think that still remains a tenet of our profession.
I love it. I love it. Measuring what we see. Thank you for bringing that to our attention. And all of us in academia are always quoting many of those papers and centennial, works of the past. Thank you so much. And Dr. Fay Horak, I would like to present that same question to you. What has helped you through your journey and your career?
Well, in physical therapy school at the University of Wisconsin, I fell in love with neuroscience, especially after my mother got brain cancer. And I started reading everything I could read up about that. But then when I graduated, I took a 2-week course on PNF at Northwestern University in Chicago. And that's where I met Dorothy Voss. Dr. Dorothy Voss showed me how to combine my love of neuroscience with the love of physical therapy, because she talked about muscle spindles, she talked about stretch reflexes, she talked about how the brain controls movement, and tried to bring that into a new way of thinking about how we can treat people with neurological disorders. And I always thought of those as kind of separate before that. And of course, I was familiar with the New Step journal. There's this great big summary of the science behind our neurological approaches. And I was struck by how, although they were very good, it seemed like all the science were by men who were scientists, and all the clinical practice by women who were clinicians, and there were no clinicians who were scientists, and there was no women who were scientists. And so in 1975, I decided to get my master's in neurophysiology in Minnesota so I could try to close that gap, thinking, oh, it must be out there, the research is there, so I'll just have to search the libraries for, that was before PubMed, before you had to search the libraries for the medical science underlying our neurological treatment. And I found I couldn't get a master's degree in that because the gap was too big between the science. The science asked in anesthetized animals did not apply very well to our neurological humans. And so went to the University of Washington, where Dr. Marge Anderson, I'm a true mentor, helped me see that if it was going to be done, we had to do it ourselves, close the gap. And she also encouraged me to go on with my life and have a baby while I was getting a PhD. And that is an important lesson as physical therapists, that we have a family life as well as a professional life, and that can be balanced. And another person who influenced me in both those ways, both in closing the gap between the science and the practice, and in closing the gap between your family life and your professional life, was Anne Shumway Cook. Because Anne and I taught classes for 30 years to physical therapists on weekends, and we spent all those hotel room times talking about the science and the practice, as well as how the heck do you have 2 children and get everything done that you need to get for your husband and your children, and do research and be a physical therapist. So there's many people that played an important role for me.
And it's amazing. Thank you for that story, sharing it. And I believe that you were the only physical therapist to receive the Merit Award from NIH, which means that for 30 years, you've had consistent funding from NIH. I think you've made a public statement about female scientists. Thank you, Dr. Horak. And one more commenter, our panelist, Dr. Pam Duncan. Please, share your
Thank you,
comments.
Denise. I think both Fay and Anne and Don have just highlighted the tremendous pioneers in this profession. And we know from neurological therapy that Signe Brunstam and Dorothy Voss and Marge Anderson and Anne Van Sant and Fay Horak have really led the way in creating the science. So first of all, I'd like to acknowledge both Anne and Fay before I look back. They're not that far back, but I used to look at them and say, I just want to be as smart as they are. And I was just in awe of the neuroscience and the funding and the brilliance of Fay Horak and Anne Van Sant. So I've been privileged in my career to call them colleagues, and I'm still in awe of them today. because I want to recognize them as pioneers, and they set forth certainly as role models for us how to move forward in NIH funding, and Anne and her incredible leadership in education and within the section. But if I look back on my own personal professional career way back, I said when I graduated from Columbia University as an undergrad, there'd be two things I would never do: research and teaching. And now, some almost 44 years later, here I am. And I want to attribute that to Margaret Moore. Margaret Moore was in the generation of Helen Hislop, and Margaret shared with Helen the vision that if physical therapy was going to advance, physical therapists had to receive degrees beyond their professional degree. And Margaret set up at the University of North Carolina a master's degree program, and it was the Master's of College Arts and Teaching, which really had nothing to do about college teaching. But she saw this as an avenue to get therapists to go forward with the master's and then propel them for a PhD. So Margaret was also what I would call a sponsor. And there's a difference between a sponsor and a mentor. You know, you go see your mentor and they tell you, you know, here's the way you design the study, or here's what you should do. But a sponsor teaches you to network, and they advocate for you. And so Margaret Moore was the epitome of a networker. She was certainly a major leader, and all of you know that she is recognized in perpetuity award by the American Physical Therapy Association. But what I learned from Margaret, that at the University of North Carolina, she did not stay in the silos of PT. She was actually an assistant dean in the medical school, established the college, and then taught all of us how to network with maternal and child health, our pediatric colleagues, and the neurological therapy. So she said, it's not just about physical therapy, it's about network. So Margaret thought about systems of care. So we look at individuals like Fay and Anne and Don, and also pioneers like Steve Wolf, who were really networked across disciplines. And I would say that my career has advanced, and I represent physical therapy beyond our profession in international networks. I've broken glass ceilings. I was the first woman. I was awarded the David Sherman Lecture in February, the first woman in the American Heart Association, and the first non-physician to ever get this recognition for years of contribution. But I would attribute that to Margaret Moore, teaching us how to network and move beyond our profession and the value of physical therapists and our science as we move forward. So I also have to say I stood on the giants of many individuals outside of physical therapy. The late Jim Davis, who was a neurologist, who called me over as a young therapist at Duke and said, I think you're kind of smart, and my patients I refer to you, they seem to do pretty well. Come here and tell me how Pam, I'm going to do a trial in recovery, amphetamine, and stroke. So tell me how you measure motor recovery. And I said, I don't know. How do I do it? He said, I want a valid and reliable measure. And I said, well, what does validity and reliability mean? And I went to the library before PubMed and sat in the library for hours and found the 1975 citation for the Fugel-Meyer assessment.
Awesome.
And introduced it, and then went back to school to get a PhD to learn about validity and all.
And so, she's been running ever since. Awesome, awesome. Well, as you were talking, our audience has been quite impressed with all of you. And there is a question that I'd like to present to all of you. And the question is, many of you have mentioned the role of mentors in your career development. So what do you see are the best ways to mentor students or younger clinicians into clinical and research excellence? So any one of you can answer that or address that question.
I usually think of, here, come with me. And either we went to the clinic or we went to collect data, one or the other. And I just always talk out loud what I was thinking. And I think that helps a little bit. And I have one very successful student right now. Pam, you'll be excited about this. He he's at Hopkins, but he went away to get his degrees in public health. And he's running something for Hopkins related to personal protective equipment now, in charge of training and recertification of people for PPE. And he just got a big award from an acute care organization and APTA.
Well, I think that's one thing that a good mentor does, Anne, is make sure that their students and their mentees excel more than they have ever excelled, to make sure they're the ones getting the grants, they're the ones getting the new ideas and the new papers, and networking is an important part of that, of course, outside of physical therapy or their own research area.
Certainly always being present in your office, emails, and put yourself in their position, be empathetic of what it was like in that role. And that's always helped me.
Good
I'd like to
comment.
speak to one issue too that Fay alluded to. I mentor all individuals now, cadres of physicians to therapists to exercise physiologists. I think the struggle that is more apparent. I mean, I think Fay alluded to it, but I think there are more struggles now with women in science than even when we grew up. And I spend a lot of time mentoring women about this is a tough journey. It's not easy, but it requires persistence and it requires support from family and friends. And there are also times in life you have to, set priorities and shift sometimes. But we have to build a very embrace and supporting network. And I've been very vocal about the higher you go up in the food chain in science, especially in the medical field, the more gender bias there is. It's incredible. There are articles in the New England Journal. It's worse in engineering. There's so much gender bias. And so I spend a lot of time speaking to women about, okay, there's gender bias. And you know what? I learned from Margaret Moore, you be outspoken and persistent. You don't tolerate it. And at the end of the day, you have to stay focused on your science, and no one will ever stop that progression. So I don't think we can get distracted, but we really have to be able to recognize this. It is, in my opinion, I think it's worse now than even when I started. And it's more subliminal sometimes, but it is overwhelming. And women come up to me at national meetings and they said, how did you break this glass ceiling? And I said, well, I confronted it when I saw it, and I'm going to mentor you and help you. So I spend a lot of time now encouraging women to continue to, whatever their choices in life, to have families or not, but you can do this, but you need a support network to make it happen, and stick with the science. And at 70 years of age, I'm still standing.
Go, go, go. I'm here cheering you on. Well, thank you for those wonderful comments. And all of us are saying, mentor me, because all of that wisdom, I'm glad to hear that, sharing that to build that new legacy. That's what we're always looking for. Well, the time now is for us to take a celebration break. So we would like to include all of the audience in this occasion by sharing some prizes. So throughout the night, we're going to give away some gift certificates to the ANPT Synapse Online Education Center. And these certificates are going to be awarded to the various ones who are participating in tonight's event. Now, you know that the Synapse Online Education Center is a site where you have over 30 peer-reviewed evidence-based courses and webinars on a variety of neuro topics. Therefore, during this first break, we would like to give away 6 $25 gift certificates. So when you hear me call your name, please enter your email into the Q&A section in that little box there, and we will send you your certificate tomorrow by email. So I'd like for these individuals to enter your email addresses into the Q&A. First one, Jennifer Kahn, K-A-H-N. Second one is Sherry Kiami, K-I-A-M-I. Next one is Huting Gao, G-O-H. Next is Michelle Chung, C-H-U-N-G. Next is Perminder Paget, P-A-D-G-E-T-T, sorry. And then the last one is Barbara Darkangelo. That's D-A-R-K-A-N-G-E-L-O. All 6 of you have won a $25 gift certificate. And please put your emails into the chat box to make sure that you're here to claim your certificates. Thank you. Well, we've taken a journey to the past, and as promised, it's time for us to think about where we are at present. So, our next question that we're going to present to our panelists is this. Truly, the year 2020 was a challenge for those in our profession. In your opinion, what might be important lessons learned to help prepare for 2021? And the first one I'd like to share this question with is Dr. Neumann.
Well, certainly the full answer to a question like this requires input from many others, particularly our clinical colleagues who, many of whom dealt closer than I did with the pandemic. But even before the pandemic took hold in, was that March 11th, 2020, or whatever the date was, both the clinical and the academic sides of our profession had received subtle pressures to expand our services through either remote teaching or telehealth technologies. Now, justifications for these changes were actually notable, valid, and they range from more financial affordability to improved accessibility. I think it's fair to say that a lot of us were somewhat reluctant about this change, but the pandemic forced us to change, at least temporarily, and in effect allowed us to gain experiences that would have otherwise taken years. So I'm sure we can all list positives of distance learning and telehealth, and I'm sure we can all list some negatives. But now being more informed because of our experiences allows us to make, I think, more solid arguments for or against these changes. So I'm hoping that in our next question and answer session, some of these ideas can be also addressed by other panelists and audience. Thank you.
Good comment. Thank you. Makes you want to think, there are some positives and negatives. Thank you for mixing that up and comparing the two. Dr. Horak, what are your views on this question?
Well, I also believe that pandemic has taught us things, and it certainly taught us that we need to find a better way for more people to access physical therapy, both based on their socioeconomic and minority status, as well as based on where they live, and getting treatment to people in their own homes. Even as a full-time researcher, as I am, I had to pivot and see that research can happen virtually at a distance. But so many chronic neurologic diseases like Parkinson's disease and MS and almost every other, these people require lifelong PT, and they should not be interrupted when they can't get to the clinic. And rural areas, tribal areas, minority areas, people with disabilities who can't drive, they deserve high quality rehabilitation where they live. And people who are aging in place and home deserve good quality physical therapy, even if it has to be offered at a distance. And I think it's more than just a phone call to see if they have pain or if they can do their exercises. We need to find, validate and optimize and fund telerehabilitation. I really think it's the one way we're going to have the most outreach to people who really need it. And it's going to allow us to help people do their exercises correctly and frequently and safely, not just when we're seeing them in the clinic, but every day at home in their real life.
Yes, yes, I totally agree with you. We're seeing that telehealth cannot take the place of that physical presence. Good comments. Dr. Duncan, how do you feel about this question?
Well, I think Don and Fay have just highlighted the transformation we've had, and which would have probably taken us years if we'd had not had the stimulus of the pandemic. So I think the ability now and the rapid acceleration of innovation technology for telerehab is going to be a lasting effect. But I'd like to focus on this issue, is that we have been not only in the middle of the pandemic, but we're in the middle of a social chaos. And we're in the middle of political chaos. What really has to drive us in our world is, as researchers, we're taught very early on in life, we're not here to prove our hypothesis, we're here to question our hypothesis. We gather evidence, we evaluate the evidence, and we critically, sometimes there's conflicting evidence, but we interpret the evidence, and that evidence drives us forward. And I think that we have to bring that to our clinical practice, our day-to-day living, and our scientific agenda as well. And so I think we are seeing roll out in real time in the pandemic. We're seeing racial and social disparities. We're seeing that we're having to evaluate in real time a virus that we didn't know existed last year this time. And we're actually seeing the evolution of science verbatim. And no one can ever say that we are not going to transform the way we do clinical trials or how quickly we've rolled out these vaccines. But the sad news is, in my own community today, we are totally abandoning the public health initiative that's required to reach out. Not they come to us, but we reach out and deliver the vaccine to the patients who are disabled, who are homebound, and who are on Meals on Wheels, for example. So I'm working with the Area Agency on Aging and on the state calls with them today, and there's no plan in the state initiative to reach out for people who are homebound, Meals on Wheels, and who don't have the transportation to stand in line. And I said, okay, we can change that. Get all the Area Agency on Aging together. We develop a plan, and we go to the CDC at the state level and say, we are going to be the Area Agency on Aging, and we're going to reach out to all our colleagues in therapy and nursing and physicians to volunteer, and people to go volunteer to just register. This is a public health crisis. And the worst thing that we can do in this situation is to think the medical systems are going to solve it. They are not. So I think that we have to work with our community-based agencies like the Area Agency on Aging. And each one of you, I invite you to reach out to your Area Agency on Aging and say, what are you doing? I will volunteer, and we'll get volunteers to help go out in the community. And I think that we will only address this with a public health perspective.
Yes.
And physical therapists have a major role, and Fay's already mentioned it. And if I go back to the past, when I first started physical therapy, I saw a lot of Parkinson's disease patients. And you know what a common denominator was? They had the flu in 1918.
Yeah.
And so we already know the long-term sequelae of this is going to be neurological, respiratory, and physical therapists cannot be an episode of care. It's going to be a trajectory of managing these patients in the long term. And then that is a public health chronic disease management perspective, not just I've got the cure and that's it.
That's food for thought. Thank you for bringing that comment up. And it's kind of causing my anxiety a little bit, Dr. Duncan.
But out of
advocating for our patients, I like that. Yes.
anxiety, create action, don't
Yes.
create whining.
Yes, yes. Well, Dr. Van Sant, what's your view on all of this? We're waiting for your opinion on this.
Well, I sit home now that I'm retired and I think a lot, but I live in a neighborhood full of children. I've been watching them get through this and thinking a lot about children and what they're facing in this interesting year. And the very first thing I think about, and I cannot wake up in the morning without thinking about white privilege. And it really, really grates on my soul. So I think, if anything, that I would take from this, the first lesson is white privilege and what do we do about it? How do we address that as professionals? What are we willing to do? I've had some conversations with some of my aged colleagues who are still working, and some of the thoughts that are going through their minds as they look at the educational programs. I know PT has had many, many attempts at increasing minority participation and lots of different efforts, but it doesn't take.
Yeah.
Look around, it does not take.
Yeah.
We have to get real, and we have to do what needs to be done to make sure that our profession is representative of our nation. And then the second thing I think about is our role as health educators. The whole idea of social distancing, how diseases transmitted, things that us know because we're health professionals. My neighbors don't know, or they don't understand, and they're educated, but there's no health education anymore in public schools. In colleges, nobody is required to take anything related to health as a part of a core curriculum. And we need a health educated public. And to be honest, if I had it to do over again, I'd follow Pam and go into public health along with my PT degree, because I think it gives you a broader perspective of the world and what our role as health professionals really are. So those are the lessons that I've learned, and they're with me every single day. I
Yeah.
look around and yeah.
And we're also the same. I mean, we've got some big lessons that we're learning also. And to all the panelists, thank you for highlighting all of these lessons that we should learn. In fact, one of the questions that we have right now is helping others to learn as we have learned. We have a question that is posted for all of you, and let me read it to you. It's submitted by Dr. Mike Studer. You might recognize that name. But he says, Doctors Horak, Duncan, Neumann, and Sant, you come from 4 quite different fields within neurologic PT. Degenerative disease and vestibular, stroke, SCI, and pediatrics, respectively. You are all very well known throughout physical therapy and very accomplished as authorities in your areas of expertise. Similar to the question that we have about youth sports, my question is to specialize or cross-train, meaning, would you advise that younger practitioners find an area of focus or passion and specialize? If not, when is it time to specialize and excel? Interesting question. That
Well, I
person.
think something like that really is, very unique to the circumstances. I know myself, I started in spinal cord injury rehabilitation, and I really loved that because I thought it gave me a very broad perspective of seeing the entire person, the home, and everything else. And only after that did I realize that, I lost a little bit because I did not go to the various different areas. But even though that specialty stayed with me, I still think I learned quite a bit of lessons for it. I can see both sides. I think specialties are important because you can specialize and put a lot of time into it. But I think that's part of the PT education, is to try to get a balanced platform of experiences before you get out in the clinic. So I can really see both ideas, but I think, generalist training is good, but I think, being a specialist really takes that time to do that. And often it takes that time and experience to become a specialist. but I'm sure there's all different ways of getting to that level.
Yeah. Any other words of wisdom for someone else? Is this?
I think it really, like Don says, it's somewhat individualized. If you have a passion, I have seen very frustrated students who've been told by a gazillion people they have to go do a general rehab or a general hospital experience first and before they should specialize. But the passion isn't there and they just can't wait to get out of that first experience to get into what they really love.
Wow.
And so if you're that kind of person, then I guess specialization is where you start. It doesn't mean that you're always going to be a specialist. I mean, you can cross-train later in life. If we look back on our own careers, I never would have thought I would do anything in administration, so I cross-trained later in life. You know, it just depends on the individual, and I think that it's more important in PT that you have a passion for what you're doing.
Yeah, yeah, I agree. I agree. Any other comments? Well, I like to take another celebration break because it's time to give out some more gifts to our participants. Well, we're going to pause again and give away the ANPT Synapse Online Education Center prizes. And this time we are awarding two $50 certificates. I didn't hear any clapping out there, but yes, a couple of cheers. And the awardees are Kathleen Trapani, Trapani, and the other is Zenobia Crawford, Crawford. Both of you, $50. Congratulations. And once again, put your email into the Q&A so that you can get your certificates emailed to you. So with all this excitement, it's time for us to go into our third section, our last section question. And that question is, as a thought leader, you have been most successful in thinking about new directions for our profession. If you had a crystal ball about the future of our profession over the next 100 years, what would you want to see? And the first one I'd present this question to is Dr. Fay Horak.
100 years is a long time.
I know.
I'm going to take a stab at it. And I think two things that, and you'll find out why. I think that wearable technology is going to be integrated into almost every aspect of PT evaluation and treatment of movement disorders. And secondly, that wearable technology will enable us to be more effective in evaluation and treatment of people in their own homes when we're far from them. Of course, I have a potential conflict of interest because I helped develop a small company that makes small wearable sensors that quantifies walking and balance and body kinematics. And now I work part-time for another company that bought that small company. And as a chief scientific officer of wearable technology, but they don't sell the physical therapists, they're not focused on physical therapy. But I do think that it can make a difference because the same assessments we like to do, looking at gait, timed up and go, 5 times sit to stand, you can get quantitative measures that are much more finely tuned to small changes for the better or worse in our patients. And you can get new kinds of assessments of everyday life, how a patient's knee range of motion is when they go up and down their stairs, you know, how are they turning, how fast are they turning, the 1,000 times that they turn in a day. And also about quality of exercise, not only whether people are doing their exercises at home, but how are they moving? What's the coordination pattern that they're using when they're exercising at home? A therapist will be able to see that. They'll see it on their computer when the patients are doing it and after they're doing it, and you won't have to guess anymore. So I really think that wearable technology will transform physical therapy in the future.
I'm a believer. You see, I have 2 of them on.
Yeah, me too.
Dr. Duncan, I'll present the same question to you.
If I took my answer, but I think we're going to evolve over the next 100 years with tremendous technology and be able to interface that in our programs and to be able to monitor. But I also think we're going to have a lot of computer brain interface. I think programs like the Wadsworth Center in Albany and other places, that we will actually be able to think and move our extremities in the future in the presence of paralysis. And that is a long journey, but I think innovation and technology will put us on a different plane. I also think in the next 100 years, we will have a much more holistic approach, and we will bridge it from the medical model to, and I pray, to a public health model, because as you bring in these wearable technologies and innovation, it just is not a medical episode of care any longer. It's a long-term trajectory of how we'll be able to manage. But I'd like to draw on something that Anne said too. Rather than telling you what 100 years will look like, who in the world would have thought we'd be where we are when I started my career, almost 44 years ago. There are certain qualities and traits in life that sustain us throughout all decades and centuries. And number one, you live life with a purpose. And we understand what the scope and purpose of physical therapy is. And I hope that we never lose the purpose, that we really are ultimately about improving the quality of life of all those we serve. And that we do that as physical therapists, often focusing on the motor components of it and physical function. But we carry that vision and purpose throughout life. And the second thing is that we think about systems and sustainability of what we do, and that we lead with clinical integrity, and we always lead with integrity in evaluating the science and be at the forefront of bringing to the front lines of practice what we do to expand the ability of all individuals from every social and racial and economic perspective to do that. So I hope that we carry those values, and the values of persistence, and that we are outspoken, that we network. Those are characteristics, and don't ever let your talent take you where your character can't keep you.
Good advice. I love it. I love it. And Dr. Van Sant, what are your views about this? What's the future?
Well, I'm just excited to hear about the wearable technology. I think it's way cool. I hope that we can keep a little bit of human touch going too.
Yeah.
So Fay, there's a challenge for you. If I touch here, will they feel it out in the community?
Yes.
I don't know. I think you probably could figure that one out though. I'll probably make something that would do that.
Yeah.
I also think that this notion of diagnosis that people haven't really talked about tonight is something that we hopefully, I hope it doesn't take 100 years, but I hope that we are diagnosticians in that future, looking at human movement and making real diagnoses that lead to specific interventions, science-based. And I think that would much improve, let's say, the future of our profession for the long term to be sustained if we are able to actually employ diagnostics in what we're doing for the human movement system.
I love that. And I have a feeling that Dr. Neumann might feel similar to you. Dr. Neumann, how are your feelings about the future?
Well, I hope in the year 2121, the highest quality of medicine, including physical therapy, will be available and affordable to all. Now, the technology that will be here in the next century will certainly seem to support this. But will the healthcare infrastructure from which we practice, will that be able to deliver such a reality? Now, considering all the likely advances in technology, medicine, genetics that will be made in the next century, will there still be a demand for our services? Well, I think yes. Traumatic accidents will still happen. Unfortunately, some babies will still have trauma of a difficult birth, The nervous system will still be subjected to insult and disease, and function of our elderly will inevitably decline, and they will eventually succumb to falling, especially considering what the life expectancy will be in 2121. So we will indeed have a vital role in healthcare. And furthermore, I would like to see our profession be a champion of non-pharmacologic treatment of pain and in the promotion of preventative healthcare. And finally, in 100 years, I hope physical therapy remains a respected medical-based profession whose practice is founded in science, but delivered with compassion. Regardless how sophisticated our approach to patient care comes, I hope that PT remembers its roots, that we take pride and honor in delivering our most basic services, like helping someone stand up in the parallel bars when they take their first step after a total hip or a stroke. I hope for a continued strong and humble profession.
I love it. I love it. I'm with you all the way. Thank you for such great comments. And I know I tell my students, get ready for outer space. You know, we need to have physical therapy out there in outer space. So that's a new special interest group that we'll have in neurologic physical therapy. But thinking about our students, we do also have a question from the audience while you were speaking. The question is, as a profession, how can we standardize DPT student engagement in research, since I believe that engagement in research helps build a clinician to lead the clinic with their critical thinking skills? So that's the question to our panelists, pulling in the students.
Probably one of the hardest questions from an academic standpoint, because we think about that quite a bit.
Yeah.
I mean, all universities, all 220 universities we have are certainly different, but I know that it's quite often in a DPT program to do enough research that you can actually learn to be an independent researcher. There's kind of an inherent conflict in that. So part of the solution could be the DPT PhD model, similar to our MD PhD colleagues. I mean, or we promote continued PhD level training after the DPT, and I think that is important.
I agree. I agree.
I think that I'm not sure it can happen in every physical therapy program, but I think that if you have active researchers teaching in, the DPT program, engaging the DPT students in your research, not, necessarily in overwhelming numbers, but engaging them in research is one of the easiest ways to do it. That's where they get their critical thinking skills and so on. So I think it can be done. I was in 2 different programs at Temple and Medical College of Virginia that did that. And many of those students went on to get a PhD later on, just by having their appetite whetted.
No, good thoughts. Good
I,
thoughts.
I think this is a conflict we've had, for years, but I don't think it's realistic. It is not realistic to think that any basic professional degree will prepare you to become an independent researcher. You don't even have the credentials to do that. You don't graduate from medical school with those capabilities either anymore. But I think, as Anne and Don are referring to, is that for those who are interested at this point in time in their DPTs, just like their clinical rotations, there could be a clinical research rotation with accomplished researchers. And there's so much to learn from being an RA or having medical students in our research program that participate, and then they learn and engage just as they do other things. And as Don alluded, I think if you're going to get, all of us went on to get advanced degrees to become a researcher, and It's a DPT PhD degree, or you go into, public health and neuroscience or education. But that's the journey.
I love it. I love it.
One thing that's
And-
happened is, I've had more than 10 research coordinators who went on to PT school. So between their undergraduate and their DPT, they learned about research projects by working in our laboratory running research projects. And I think those people eventually will go on to, even if they don't get advanced degrees, they will think differently about their patients and how to address hypotheses they have about their patients.
I agree. I agree. Well, I have one more question that I'd like to squeeze in because it's worth discussion. And this is coming from our audience. Please share your thoughts on the movement system diagnosis discussion in our profession. Do you think that this might steward changes in our current academy structures, ways of structuring professional dialogues, clinical practice, and clinical research? If so, how might this future state look? Because we've been talking about the
Sounds like
movement system.
Dr. Solomon's out there, maybe.
I know. I was wondering who presented that question to you.
I followed her work for years, and I think it's excellent work, and it's really a good way to systematically understand movement. And I feel really strongly about the work she's done and her colleagues. And just more work needs to come out of that in continued publications from that work, and more cross training and more people understanding it.
Yeah.
I'm a little biased because I've been involved in it since it got started with Shirley. But I think that if people think to their own knowledge of looking at someone with a movement disorder that they're familiar with, if they are paying attention to what they're seeing over time, begin to make intuitive diagnostic decisions. They see things in one patient that they later apply to another patient, and they think, well, that worked. And there is a unbelievable amount of knowledge sitting in the heads of experienced clinicians who see movement disorders day after day and see patterns in them that can help inform their practice. I got that thought proven out when we had some of our meetings with experienced clinicians when we were doing the movement system diagnosis work at CSM and at other meetings. And we would get experienced clinicians in the room, and they would start talking to each other, and they made intuitive sense to their colleagues, and they were able to describe syndromes, which is what this movement system diagnosis thing is all about. That, from my perspective, only PTs could see that.
Yeah.
Only people who look day after day and are watching and looking at the test results that they take and watching them progress over time. But it is the foundation for putting groups of patients together in meaningful groups that respond to specific therapies. We always have patients who don't respond to what we're doing. Well, maybe they're in the wrong classification and they should be getting a different kind of intervention. So I am absolutely in favor of continued work. It's going to be hard work, but continued work to get some diagnostic research done. And of course, once we get syndromes identified, then we can start seeing what treatments best affect a positive outcome for those folks. So whether it's structures, academy structures, I'm not quite sure of that. I can't answer that because I don't know exactly what is meant by academy structures. But that's okay.
But it's food for thought. It's food for thought.
Yes, it is food for thought.
I'm not as versed in this, obviously, and I certainly know Anne Shirley's work, but I don't know it that well and don't know it certainly as well as Anne or Don. But I would also caution us that we can't look at You know, I'm in stroke. I've spent a life in stroke. And Signe Brentstrom did a brilliant, she was brilliant in how she classified the stages of recovery. And well, almost 100 years later, they're still proving to be right. You can look at these different levels of stages, and a good clinician can classify you as a Brunstrom stage 1, you know, through 4.
My point exactly, Pam.
Yeah, but on the other hand, in today's technology, I know as a skilled clinician, one of the criteria in that classification was, do I have an individual finger movement? But by combining imaging and neuroscience, in fact, I'm pretty sure there's a study that's going to get funded where we combine not only the analysis of the movement, but understanding what systems are left to be able to control that. And I think if you look at the work like of Steve Kramer and understanding, there's a big difference between those who have a cortical spinal tract and those who don't left. And so we've got to merge it and expand our skills beyond just thinking of movement classification, but combined, and imaging and so forth will emerge over time. And that we actually have underlying biomarkers. We established biomarkers of these different movement disorders. I mean, I have colleagues, one that I'm mentoring right now, who's an expert in type 2 muscular dystrophy, and we've always thought of it as a motor problem and atrophy. And right now, we clearly understand, and moving that work forward to understand that it's much more than just muscle. It actually is brain. And you have to be able to look at biomarkers and images as MRI and other biomarkers to do it. So if we're going to advance it and you're thinking about the future, you're going to have to bring these type of images and biomarkers together with your analysis of the movement to make it happen.
You know,
Absolutely.
I agree with you, because there's so much more knowledge now about genetics too.
Yes.
And we're finding that different genetic types of ataxia, for instance, have very different posture and gait problems. And if we didn't, it's a lot easier to classify them if we know the person's genetics, you know, and most people are getting that. And we can treat them differently, and we can look for patterns of movement that are different, knowing their genetic predispositions. So I think by combining across different areas of medicine, we can really contribute. And that goes back to your networking, Pam, how we have to work together with other people who know more than us on other areas of health.
Yes.
Right.
What brilliant ideas, exciting, you know, kind of responses. I mean, I love what you guys are bringing forth. You know, one thing that you have done this evening is you've planted the seeds of thought to make us, you know, step back and reflect about where we've been and where we are and where we're going. So the clock on the wall is telling us, unfortunately, we've got to stop our conversation. And I'm going like, oh, I wish I could have them talk longer. But unfortunately, it's time for us to come to closure with our event. And before we close, I do have a couple more winners. So I need to squeeze that in before we end our event. And we have 4 winners with some more gift certificates. Christine Clarkin, CLARKIN, $50 gift certificate to you. And Julie Schwertferger, that's SCHWERTFEGER, that's $50 for you. And then we have Cindy Flommeland with FLOM-MELAND, $75 certificate. Woo, I hear the screams and shouts and excitement there. And the last one is Paz Leos, LEOS. You have $75 gift certificate coming. Well, like I said, the clock on the wall says it's time for us to end our special event. And it's telling us also that it's time for us to start thinking about our next 100 years of physical therapy practice. We'd like to thank our panelists again for helping us in our reflections of the past, present, and future of neurologic physical therapy practice. We've enjoyed putting on this event for you, and we hope that you've enjoyed participating. So, from all of us, thank you and good night.